Welcome back to our podcast. My name is Dr. Edward Ngwenya, and we will be discussing vascular anomalies. Vascular anomalies in this podcast. As I repeat in all our podcasts, the assumption is that you have read, you have an understanding, and this is just to give a succinct, brief overview and touch on particular points, but not to replace your learning. So what are malformations? What are, these tumors? What is vascular anomalies? So we can divide into two, as already I've done. And this has been classified actually by Mulliken, who first introduced this with Glowacki, in 1982, if I recall properly. Yes, 1982, I think. And they came with the first classification of differentiating these tumors, which they put mainly on the side hemangioma there, and then these anomalies or malformations that you may get. And this has gone through a whole range of evolution, and the classification has changed as time has gone and included various things. As we know, the International Society of the Study for Vascular Anomalies, the ISSVA, came together in 1996, brought through a classification. In 2014, in Australia, in Melbourne, came through and brought in another classification. But the one that we're currently using now was the one that we were at a meeting in Amsterdam in 2018, where then a new classification then came. And that's what we are currently using right now, and the one that I would be speaking into. So what we can differentiate, I assume you know what a tumor is. It's a growth, that's the abnormal proliferation of tissue as compared to, you call it, its neighbor, and it's growing at a rapid rate. The mitotic count is much higher, and this is a tumor versus a malformation, which is not a tumor, and it's as the word states, an abnormality in the development of that particular organ or that particular structure congenitally. So how do we then differentiate this? So let's look at our classification. So we divide it into tumors, which may be benign, they may be borderline or locally aggressive, and they may be malignant. Benign, locally aggressive or borderline, and malignant. Now, the one that comes out most commonly, as we know, in benign tumors would be our hemangioma. Now, hemangioma in itself can further be divided into either infantile or congenital. Now, infantile, we know, quite common versus the latter, and that's the one that would be more GLUT positive, distinctive. It is the sine qua non of infantile hemangioma versus congenital, which would be GLUT negative. Now, congenital can further be divided into three, and the third being introduced in 2014-2018 classification. It can either be rapidly involuting congenital hemangioma, these are the rich. It can be non-involuting, these are the niche. Or it can be partially involuting, a congenital hemangioma. This being the rich, the pitch, and the niche. These being the congenital hemangiomas. Then we've got epithelioid hemangiomas under the benign tumors. Then we've got tuft angiomas. Tuft Angiomas, I would like to put an asterisk there. Let's just tag that one and flag it there, because it seems this one with the latter one, which I will mention under borderline, the caposiform hemangioendothelioma, seems to be a spectrum, a continuation, rather, but we'll speak more into that, and they are special in something specific, which we'll go into. Then we've got our spindle cell hemangioma. We've got our pyogenic granuloma. This actually, being a misnomer in term, pyogenic, it's not infective in any way. It is not granulomatous in any way. It is actually a lobular capillary hemangioma, and we call it lobular capillary hemangioma. And maybe while we are here, we can just quickly deal with it and say this particular one, generally it's something that, commonly you'd get it occurring in, the first decade of life. And it's tough, especially in pediatric population, to differentiate it from melanoma, as they may present the same. And so often for us in these treatments, in the treatment of this, as these are irritating, often bleeding, we would rather say, it may be wiser to cut it out, excise it, as it may be so tough to differentiate it from a melanoma, rather than to leave it and let it grow. And often, as I've mentioned, these are, often quite irritating and, really a problem to the patient. They bleed, they ulcerate, and they can grow as with time. So that's pyogenic or lobular capillary hemangioma, pyogenic granuloma. Now we've dealt with the benign tumors. Then there are the borderline tumors. Now the borderlines are what? Caposiform hemangioendothelioma. Here we've also got our retiform hemangioendothelioma, our composite hemangioendothelioma. We've got our PILA here, PILA. We've got Kaposi's sarcoma. Of course, discovered by what was the gentleman Maritz Kaposi, who coined the term, naming it after himself, Kaposi sarcoma. Now these are locally aggressive, quite a problem, and we would then treat them a bit differently, and rather more aggressively as compared to the benign hemangiomas. And then, of course, we've got a malignant side to these. These are your angiosarcomas, your epithelioid hemangioendotheliomas, and then others that will fall within that category. And these are malignant. And of course, I need not tell you what the management therein would be. Now, specific to this, we then have our malformations on the other side. And malformations, we can break them up into 4 groups. There are simple, they're either simple, which are limited to a particular structure, whether it's venous, it's capillary, it's arteriovenous malformations, or it can be lymphatic, which can be macrocystic or microcystic. Or they can be combined, where you can get, venous and lymphatic combined, or capillary, lymphatic, venous, or whatever combinations you may then get. That's the other group. So simple, combined. They may also be of a major named vessel. So it may be from a specific vessel. Look at something like an aorta, even a AAA. It's an abnormality, an abdominal aortic aneurysm that's specific to that known vessel. We would throw it under there. And then the last group would be associated with other anomalies. So these would be usually our syndromes, our group of syndromes, such as, example, Maffucci syndrome, which would be patients who would have your enchondromas on the hand, actually 160 cases that are known or reported worldwide since these days may occur later in life, and you see them on the hands, specifically these enchondromas and these blurbs, these venous malformations that they then have on limited to the hands. And we usually we treat them specifically. Some we just watch. Very few cases that we've seen. We've actually seen a case. We have a case of a patient who has Maffucci syndrome. There are other syndromes, of course. Your triple channel syndrome, where you have your it's your capillary, your venous, with or without limb overgrowth, and then you can, with or without lymphatic, but it also has lymph overgrowth. So venous, capillary, and then limb overgrowth, and they can have with or without lymphatic malformations. And those, you would look at them, examine them specifically, look for embryonic vessels like your retained embryonic vessels, like your sciatic, your vein of Savelle, etc. So there are many that would fall within those, and I'm not going to belabor on the syndromes, but that's something you can have a look at. These are now your malformations. So also just to touch on malformations, maybe what's important to know is it's how to treat them, specifically related to things such as the AVM. Important just to know about the stages. I think if you can know about the 4 stages: the quiescent stage, where it's quiet, the expansion phase, where they get larger, destructive, where now this patient then starts to come to you and says, look, this thing is bleeding, it's really painful, it's ulcerating, etc. And those you better take seriously, because the last stage is still compensation, and that's when they may have heart failures, etc. So just succinctly, that if you can just grab that, just know something about that, and also something about lymphatic, how you would manage it, your cystic hygromas, some of the procedures that you may do for children, exit procedures, because they may have problems with breathing, your capillaries, the telangiectasias, how we can deal with that with lasers, your venous malformations and the problems they may have with the blebs, and with the phleboliths, and how we can look at those. So I'm not going to labor on those points, but that's something for you to have a look at. What I would like us to zoom into, which is something that I would like you to know, is hemangioma. Important again, just know how to differentiate hemangiomas from malformations, and that you should be able to do clinically. As we know, with hemangiomas, usually nothing is seen at birth, but malformation, they are all present at birth. They may not be evident, but as the patient grows, they grow. They, by the way, may expand with trauma, with sepsis, hormones, etc. And then, whereas hemangiomas would undergo a different growth pattern, where they actually undergo 3 processes actually, where the first stage they would rapidly undergo this process where they actually proliferate. So it's the proliferative phase that usually you must know about, that then happens with them. But then as time then goes, they then reach a plateau phase, when then afterwards they would then regress. So they proliferate, and then they would then sort of plateau, and then reach an involution phase. So proliferative phase, involuting phase, and then an involuted phase. You must just know, and just know about 30%, most would be involuted. They would disappear by 3 years old, 30%, 5 years old, 50%, 7 years old, 70%, 9 years old, 90%, etc. So generally, it already gives you an indication that these are things that we can manage conservatively. Also, cellular level, we mentioned that they expect the CLUT1 in the infantile, whereas malformations, they do not express CLUT1. And these are tumors. So they have a plum endothelium, they've got increased proliferative, increased mast cells, multi-layered basal membranes, whereas the latter, the malformations, have a flat endothelium, slower turnovers. Mast cells are normal, basal membrane is normal, it's thin. So that's how you would differentiate. And maybe hematologically, generally, as you would see, here we may see issues of Kasabag-Merit syndrome, whereas we don't see them in the malformations. They generally would have maybe primary venous stasis, and then due to that would have a consumptive coagulopathy because of the stasis, the turbulent inflow there, and then that environment assists and favors coagulation, and there would have then this localized consumptive coagulopathy. So these are just some of the things that you can have a look at, and with them skeletally, it's infrequent that they would have a mass effect on the bone. This I'm talking about your hemangiomas, but with malformations, they may have hypertrophy, either low flow or the high flow. They may even be destructive to bone. So that's something just to note on that. Okay, so how do we manage hemangiomas? Okay, so I think already we can manage them conservatively. As I've mentioned, those are the phases. There are phases that they can go through. So you can advise a patient, if you have a mother in front of you, and say, look, in the first year of life, this thing is going to grow, and it's going to rapidly grow. So the neighbors may see that, look, this is growing, and so it's okay. Don't worry, as time goes, it will involute, and you give the figures as given. Now, those are the lesions you may manage conservatively. However, you may need to intervene therapeutically. How so? Either medically, either surgically, and either ablatively, through other means that we'll speak about. And there are indications that are specific that I would like you to know. And this is what must come strong, for a patient. So generally, the way you would group any patient, and the way I like to manage my patients, is to look at the individual and say, look, here I see a hemangioma. Number one, what is the threat to life? Surgically, generally, the way we manage patients, the first thing is preservation of life. Then the preservation of function. Then we preserve form, which is the cosmesis. It's life, then function, then form. So our indications will be, what is the threat to life first? So if there's a threat to life, such as if there's a problem with bleeding and ulcerating, these are patients maybe with, hemangiomas that are ulcerated, that are bleeding. I need to intervene because it's a problem. There's a threat to life. Is it around the airway? Is there a threat to life? Is there thrombocytopenia, which is Kasabag-Merit syndrome? So generally we have this. Specifically, it seems to be there with the Tuft Angiomas and the Kaposiform hemangioepitheliomas, and that we see it predominantly there. And it was described by these two pediatricians, Kasabag and Merit, who noted that the platelets, so basically how do you define it? It's a patient who has a hemangioma or a vascular tumor, a hemangioma, plus thrombocytopenia. So what you have is entrapment of platelets there to the endothelium. So it traps then the platelets. And then the fibrinogen, as you would see, the fibrinogen would be low for these platelets, and the D-dimer subsequently would be raised. They may have anemia, but generally low platelets, low fibrins, and then an indication would be a high D-dimer. And this is in a patient with a hemangioma. That's Kasabach-Meretz syndrome. And then, of course, another threat to life may be high flow cardiomyopathy. Maybe while we are on Kasabach-Meretz syndrome, this is something, it's a threat to life. How do you treat it? Just to quickly go, please do not give these patients platelets. No. It's only what we found is that it increases the size and it makes these rapidly proliferate. And so these patients, we don't give them platelets immediately. We rather support these patients. If they need blood, we may need to give them. If we need to go in and intervene surgically and then need to embolize, we can then go and embolize under a platelet cover, or we also give our cryoprecipitates as we go into theater. But these are really a challenge to deal with. And so there are different guidelines that deal with this. If you look at either on the one side in the US, there's been some studies on the vincristine, is something that's used quite a lot. Vincristine plus steroids. Some pediatricians would then use, and then others would then say no. We then rather use vincristine plus aspirin. Works well. Others would then say no. The problem, we are afraid of Reye syndrome, REYE, especially in the pediatrics. We don't like aspirin, so we'll stick to steroids and vincristine alone. So you can just look at those different ways of treating them. But vincristine seems to be something that's coming strong. There are other drugs, of course, that are used. But certainly these are some of the ways we manage it, and then surgically we can then go in and and also then intervene, whether via embolization, surgical resection. But this is easier said than done, because this can be something that's very difficult to treat. Now, what are the other indications? Threat to function. This being sight. So you can have it in the periorbital region, and it can be there. Remember, if you've got something obstructing the eyelid and the vision that's there, and if you have it for more than 2 weeks, a week, 2 weeks already, then the brain decides, we're going to shut off that eye and we're going to favor the other eye. That we call amblyopia. And so you don't use that eye anymore, something very dangerous. So in order to restore function, we need to intervene then fast. So there are different ways. Others would say this one we need to then go out and sort out quite fast, intervene, therapeutically, and not treat conservatively. And then other ways, of course, you may then say during the day, maybe intermittently, I can tape the normal eye so that we can force the patient to use the other eye and not favor this, just to limit the amblyopia. These are just some of the things that can be done. GIT, if it's around there, if it's around the auditory canal, there's auditory canal obstruction, or very large, rapidly growing cutaneous hemangiomas that are quite debilitating to the patient, and where there's functional morbidity, there you would then want to intervene. And then, of course, if now for the form or the aesthetics, if there's increased risk of scarring or disfigurement or any lesion on the face, like your Cyrano nose, your auricles, these are particularly prone to disfigurement, the lips. So those are the ones we kind of like to then come in and then intervene in those. So the goals: preserve life, function, form, and we also want to minimize the psychological distress, both to the patient and to the family. Okay, so how do we then manage? What are these therapeutic interventions that we spoke about? We spoke about the conservative approach, First line that we know, the gold standard in terms of medicine wise, propranolol comes out very strong. Steroids was something that was used, something that is still used by various institutions, but we must just know that steroids can also be used. They can also increase the chance of rebound growth. Be able to, you must just know about that. They can arrest the growth, but what we know is they will not cause regression. You can use them intralesionally, about a dose of 3 to 5 milligrams per kilogram per dose. But generally, just be careful around the periorbital, regions, because you can cause retinal or ophthalmic artery occlusion, and of course eyelid necrosis then following. But systemically, this is where we use them at a dose of 3 milligram per kilogram per day. You would give them for about 4 to 8 weeks, and then you taper them after 2 weeks. But just be able to monitor, know about the side effects, the growth retardation, the 50% patients who would get these cushingoid faces, hypertension, immunosuppression, adrenal suppression. Generally, that's what you must know. But where we are, gold standard number one, what we are using, the first line is propranolol. So know that, and know that very well, as the first line treatment in infantile hemangiomas. Does it work for congenital hemangiomas? No, it does not work. But for infantile, which is most common, hemangiomas, the non-selective beta blocker propranolol at a 2 milligram per kilogram per day in 3 divided doses is the treatment of choice, and we give it usually continued for 12 months, generally to avoid a rebound effect. And how does it work? Now, the way that it works by blocking the noradrenaline increase. Remember, we've got those growth factors, the vascular endothelial growth factors, so it decreases that production. It also has an effect in on the renin-angiotensin ACE expressed on immature capillaries. So it plays a role there, and it decreases then the proliferation there, and also, of course, the induction of apoptosis and fat development. But of course, we know that we don't use it in patients with sick sinus syndromes or heart blocks, whether second or third degree. So just know the contraindications, and of course the side effects, because when you use it, the things that you are going to monitor are your bradycardia. You're going to monitor your heart rate. You're going to monitor your blood pressure, because you can get hypotension, and you can monitor then your glucose level, as hypoglycemia is something that you may get. Also, just other things, diarrhea and somnolence are other things that you may also then get. But just to remember, it does not work for congenital hemangiomas. What are other drugs that are there? Just be aware, vincristine, we spoke about it, and just know about its mechanism of action. Specifically, I think it's on the tubules, and how it works there. But basically, we use it mainly, we reserve it as an adjunctive treatment of mainly your resistant or life-threatening hemangiomas. And as I mentioned, for your Kasabag-Meritz syndrome, this is where we used it, because in our Tuft Angiomas, as I've mentioned, 10% of those would have your Kasabag-Meritz syndromes. So vincristine is certainly one. It does inhibit cellular proliferation, and the mechanism of action is something for you to have a look at. Interferon alpha 2A, also something to have a look at, and would also use it to those who are resistant to propranolol and steroids, but also we tend to reserve it for life-threatening hemangiomas. And of course, once you have a look at those drugs, you would know the side effects, and why we then reserve it for that. Just to mention, also important to know about injectables. like your bleomycin, because these are other modalities that we can use. So bleomycin is a big one that we can use as an intralesional, injection at any age, by the way, and at any stage. And the way it works in two ways. One, as a sclerosing agent. So it has that sclerosant effect on the endothelial cells of the cyst wall of this a hemangioma. So it assists with that as a sclerosant agent. But also the main thing is an antineoplastic agent, and we know the way it works. It chelates metal ions. How does that do? Primarily for iron. So what it does, it produces the pseudo enzyme that reacts with this oxygen to produce superoxides and hydroxide free radicals. And these are what cleave to the DNA and produce these breakages there. Generally the same way as we do get with radiation, because radiation does the same thing, uses particulate energy to then also break down to interact with water and oxygen to create this superoxide, which then cause the DNA damage. So those are the ways, and we would the standard injections about 0.3 to 0.6 milligrams per kilogram per injection. But generally the volume that's used, it's roughly that of the dimension of a hemangioma. But we would generally perform it every 3 weeks. There is a lifetime dose of 400 units that you must know about, and just know about the side effects. Big one that comes to the head is your interstitial pulmonary fibrosis, also called fibrosing alveolitis. And these are just 10% of patients can have that. So be aware. So you can use then your antioxidants, your chelators like your desferol, and some you may need to go as far as your steroids, if there's severe lung toxicity that's there. Lasers, I'm gonna put it aside. We speak about it when we talk about our laser, in our laser lectures, but generally don't work so well. They don't penetrate as deep. Your pulse dye and your NDX, these are the wavelengths of about 577, 532 nanometers. I'm talking about the Ktp Ndx Laser, which target the chromophore hemoglobin. And these generally, the primary role is in the treatment of more ulcerated hemangiomas, where we want to remove residual color from involuted hemangiomas there. And of course, surgically, we've mentioned how we can use it there. It's important to know, but just know the steps, because this is a tough procedure. Patient's gonna bleed, so you're gonna use a tourniquet. You maybe can embolize if you can. Generally difficult in hemangiomas, so you would have a tourniquet if it's in the limbs. You would have blood on standby. You may use Mulliken sutures around, as purse strings in that area, and just be able to argue and know your way around and how you're gonna treat these patients. So the target areas, maybe just know about periocular hemangiomas, how to treat those ones, and maybe just have an approach to which patients you would operate in maybe proliferative phases. Are there patients that you would, maybe if there's a risk of blood loss, iatrogenic injury, they're dangerous. They usually have inferior outcomes, but there may be others that you are forced to intervene there, and then would like to rather go, of course, in involuted stages, or the phase, but you just have a understanding of which hemangiomas you would intervene where, based on the indications, as we've mentioned: preservation of life, function, and form. So I think with this, we've got an understanding, or so we should, of our vascular anomalies, and I think this should be able, with with this, You should be able to tackle any questions that come your way when it comes to vascular anomalies. Just be able to classify it, know how to treat hemangiomas, know how to treat pyodermic granulomas, know about Tuft Angiomas, and then the borderline or locally aggressive caposiform hemangioepitheliomas, know about Kassenberg-Meretz syndrome and what challenges it presents, and then about the, your angiosarcomas that you may get, occurring from some of these tumors. It's very important. And also just to have an understanding, I think there's, when it comes to your anomalies, about the simple, whether combined major vessel that's known, and the syndromes that you may then have with them. And important just to know about things like your the stages of your AVMs, your quiescent, expansion, destructive, and decompensating. But the big thing you should know is the treatment, where we know it's conservative or therapeutic, where it can be medical, ablative, or surgical, depending on the indications. Preservation of life, function, and form is what's going to guide us. I thank you for the for this session, and I think we'll pick it up from our next session. Goodbye.